And today's session, we're going to focus on monogenic diabetes. And when I was working in practice, I always found diabetes horrendously complicated and then lots of really complicated scenarios. And so today it's great that we've got Anita Murphy, who's our genetic diabetic nurse specialist for the East of England. She also works as a diabetic nurse specialist across Norfolk and Norwich and sort of surrounding areas. And so she's got lots of experience as a diabetic nurse specialist. You mainly worked with adults, but I think also you've sort of worked with pregnant women, young people, and rare cases of diabetes. So Anita's going to do a case, introduce herself a little bit more, and then she's going to sort of talk through some case study presentations on monogenic diabetes, tell us what it is. And so it'd be great if you could all go on to mute, and if you've got any questions, if you put them in the chat or put your hand up as we go along, and Anita can answer them, and we'll also have a little bit of time for questions at the end. So Anita, over to you.
Right, have you
They're
got...
up.
Lovely. Okay, the next thing in there will be, if I'm talking, I go on next slide and nothing happens and I've got the same slide for 5 minutes, let me know as well.
Okay.
Right, lovely. Right, okay, good afternoon everybody. My name's Anita Murphy. I'm a genetic diabetes nurse. I've been seconded in this role for approximately 10 years now. And originally my secondment was through the Royal Devon and Exeter team. And then obviously it became through NHS England. I cover the Eastern GMSA, which is quite a large area. And then aside from that, my main role is as a diabetes specialist nurse based in the community in West Norfolk. So just on that front slide, and obviously it's being recorded, so you have access to these slides anyway, is the Exeter website, which is the diabetesgenes.org, which has all the information I'm going to talk about today. You can access it from there, and all the training is accessible from there as well. Now, I've moved on to my next slide. Has that moved, Annette?
It has.
Perfect. Okay, we're on a roll. Right, so I'm going to give you a brief overview of monogenic diabetes, what the scale of the issue is, and then we'll sort of go into case studies, because I think these are ways to talk about patients we've come across. Bear with me, I'm a bit croaky still. I had COVID 10 days ago, and although I'm recovered, it's left me with a bit of a sore throat. So I might stop to drink as well. I know, it's joyous.
Oh.
So monogenic diabetes, the same way as type 1 and type 2 diabetes, limits the body's ability to produce insulin, which subsequently causes glucose levels to rise. So that's why we need to act and identify it and get the right treatment. The issue we have is people can present with symptoms which are very similar to type 1 and type 2 and are often misdiagnosed as either of these. Now, unlike type 1 and type 2 diabetes, it's caused by a single gene mutation. So it's a single faulty gene. So it's not multifactorial like type 2 is. And type 1, although we don't think it's a specific gene, there are faulty genes within there. For monogenic, it's a single faulty gene that's caused it, which means that for most of our monogenic patients that we see, they have a 50% chance of passing on that faulty gene to their children. So that's why when you deal with people who've got MODY or monogenic diabetes, you're not just managing the person in front of you, you also have to take in consideration the family and other family members that might not be in your clinics.
So Anita,
yeah,
could I just say at that point, just for everybody's interest, so if somebody inherits the faulty gene for monogenic diabetes, will they always have the same presentation, or does it vary according to the individual?
It does vary. That's sometimes what makes it difficult to manage as well. It will vary. We know that for the most commonly and widely known monogenic types, there's key presentations that we expect. So we can give families that information. The only thing where it'll be different is with our mitochondrial patients. So any patient that's got a mitochondrial inherited diabetes and deafness, so MID, which we commonly call it, all of the children of the affected mother will inherit a degree of this mutation from mum, but how much will depend on the penetrance, and we can't measure that. So you will get for different children or different offspring, we will see different symptoms, and that makes it a bit more difficult. We've got a mid case we'll talk about, but yeah, it predominantly we'll have a variety of symptoms that people will know to expect, but when that will happen as well, if we do pre-symptomatic testing, that's the other issue, is you won't know when they may well present.
Right, and how serious it might be.
Yeah, within some of the more common genes, it's a bit easier because we've well documented evidence now, but the mitochondrial ones are always a little bit more difficult, and I think that's for most of the genomic issues, isn't it? Mitochondrial is always a little bit more difficult to manage.
Yeah, and when you come on to that, we can talk about mitochondrial inheritance a little bit more, because it's not as quite straightforward as the usual dominant and recessive. But I'll let you carry on. Sorry for that early question.
So the scale of the issue we've got at the minute, and I'll just go, there we go, that's probably easier. So monogenic diabetes accounts for approximately 3.6% of all diabetes in the UK for people diagnosed under the age of 30. Now, that doesn't mean the people you'll see in clinic are all young people, but it means what age were they diagnosed with. So you may well be seeing them in primary care or secondary care in their 60s and 70s, and a variety of ages, but it's what age were they actually diagnosed. So it's 3.6% is our current figure. However, 80% of people with monogenic diabetes are misdiagnosed currently. So they'll be misdiagnosed as having type 1 or type 2, and unfortunately it can take approximately 12 years from diagnosis to correct genetic diagnosis. So you might have been diagnosed with type 1, but it's taken 12 years for us to get to a monogenic diagnosis. Now that's the average, and we're getting better at it, and that's the whole point of all of this education, is that we get better at this. We pick people up sooner and we get them on the right treatment a lot earlier on. There are widespread variations in numbers of referrals still. You can see from the map, if you look at the southwest where Exeter is, that's the dark blue, and that's where the most people are picked up. And that's because obviously Exeter have always been looking for it, so they've done a lot of education in their area. Look at the rest of the UK and it's sporadic, and that's why we want to even that out, that we all become navy blue across the UK, so that our pickup rate becomes the same, so we standardise the care that we're giving. Diagnostic criteria for patients with MODY. Oh, sorry, was that someone in the... Someone got a question, or have you just left your mic on?
I can't see any questions.
No.
Oh, just a reminder to put yourself on mute, please.
Lovely. Right, I'll give me a chance to get a slurp of tea. So we're looking at, if we're diagnosing MODY, the criteria is an early onset diabetes. So diagnosed before the age of 25, ideally, and ideally in 2 family members. So when you're seeing your patients in clinic, it's good practice to get into the habit of asking, anybody else in your family have diabetes? Start asking those questions. You get to know, for those of you who work in secondary care, get to know your patients. So it's an opportunity at one of your consultations to find out a bit more about family background. We're looking at people who are not insulin dependent. So this doesn't mean the people you're seeing in clinic who have got a diagnosis of type 1, because they may well have that diagnosis, but it doesn't necessarily mean it's the correct diagnosis. So what we're looking at is, have they got a measurable C-peptide? So we're measuring their endogenous insulin levels 3 and ideally 5 years post-diagnosis of diabetes. If they're still producing significant amounts of C-peptide 5 years after diagnosis, then they're not likely to be a type 1. So that's another step towards thinking, is it MODY? Autosomal dominant inheritance pattern, which basically means you have diabetes in one parent and ideally in 2 generations, so in a grandparent or a child or a sibling we'll look at as well. And this comes back to that, if the parent has got the faulty gene, then they've got a 50% chance of passing that faulty gene on to the next generation. And because it's caused by a single gene defect, which alters beta cell function, we're not looking at type 2 patients. So we're not looking at patients that got insulin resistance. So they might have significantly elevated C-peptide. If you're looking at patients, and we get into the habit in our clinics of doing examinations, so looking under the armpits and around the back of the neck, looking for something called acanthosis nigricans, which is this dark staining. It's sometimes seen it in lines, as I say, around the back of the neck and under the armpits, and that's a good indication of insulin resistance. which is more likely type 2. So if you've got a patient, generally if your patient is very overweight with acanthosis, it's more likely to be a type 2. These are criteria, these are not definite rule outs, but they're to give you an idea of what we're looking for. We also look at clinical biomarkers before we go straight into testing. So we've already talked about doing C-peptide measurement, and then we'll do antibodies because these are important to check. So if we're asking for antibodies, I know that in our area we still do a lot of ICA, which is the islet cell antibodies, which are actually of no benefit for MODY testing. So what we suggest is that if your lab doesn't offer GAD, IA2 and zinc transporter antibodies, that you send the samples direct to Exeter, who will do that for you, and your labs can arrange that. We need to know if they're antibody negative. If they're antibody positive, then they're going to have type 1. Bear in mind, though, that only about 85% of type 1 patients will be antibody positive. So again, it's not a complete rule out, but this is all layers of information that help lead us towards looking at, are we going to be MODY testing? And in patients who are not on insulin, so obviously the antibody is not going to help because they're a type 2, they're not on insulin. Clinical features. How old are they? Were they young at diagnosis? Are they slim? Is there a family history? Is there any evidence of insulin resistance? So they're the sort of indicators before we get to testing. And then one other tool you can use before you go down the route of doing genetic testing is the MODY probability calculator, which you can download as a free app on Android or iPhone. And basically you put in the information on there, and it's quite straightforward. Age of patient at diagnosis, what sex are they? Are they treated with insulin or oral antihypoglycemics? How long were they before they went on insulin, if they are? What's the BMI? What's the HbA1c? How old are they? And is there a family member? This will then give you a percentage at the bottom of what the percentage is likely for your patient to have MODY, and it will then suggest, have you done this, have you done that? So again, when you send your request forms to the team at Exeter for MODY testing, they will ask what's the MODY calculator percentage. So it's a good idea to start getting into the habit of downloading it now so you've got it ready to go. Bear in mind, there are some limitations of the calculator. At the moment, we can only use it on a Caucasian population. There is work to look at including South Asians into that, but we don't have enough evidence in other ethnicities yet to include that in the MODY calculator, but it's something that's being worked on. And obviously, patients who are diagnosed older than 35, again, it doesn't mean they won't have MODY, it means they're less likely, but we can't put them into the calculator either. But again, it's all these are just tools and resources to start pointing you in the direction of, are we thinking MODY? So this just shows an overview of the different types of MODY out there. There are many more, but this groups the ones that are most common. So you've got your glucokinase patients, which accounts for about 32%. The most commonly identified types of MODY are the HNF1 alpha patients, and they're the ones that often present in clinic as if they were type 1. The 4 alphas present similarly to the 1 alphas, and they account for 10. Then we've got the 1 betas, and then we have the other rarer ones, which are the neonatal, the mitochondrials, and the insulin resistance. What I'm going to do now, and I will pause to take a breath if there's any questions, I'm going to go through some case studies now to cover these main types, just to give you some idea of how patients presented and what we took as next steps. So that's my first case study. Are there any questions before I launch into Charlotte's case study first off?
Just one of the questions on the calculator, Anita, was which gender patients are. So because it's usually inherited in a dominant way, apart from the mitochondrial, is there sort of any other significance to the gender at all on the?
Again, if we're dealing with people who are pregnant, we need to know inheritance patterns, and if it's mitochondrial, because it's inherited from the maternal side, so you need to know. And also, if we're looking at testing and then we're looking at counselling, it does come into, what sex or gender are you, so we know what route. And for medications, because again, if you're dealing with someone who's female and who's of childbearing age, a lot of medications we can't use, but you can if you're male. So yeah, there are lots.
Oh no, I just wondered if it altered the risk factors. That
no, it's the risk factor. Actually, there isn't a difference in the two sexes. There's no difference in which one makes you more at risk. It's just how we would manage them and what we would do with the results.
Okay,
lovely. Okay, so if we start with our first case then, so we've got Charlotte. Charlotte, when we saw her, she'd already been diagnosed during her first pregnancy. I think this was the second or third that we saw her. So diagnosed during her first pregnancy with high blood sugars, and she was treated with insulin, treated with gestational diabetes. Her BMI before pregnancy, in all of her pregnancies, she's very slim, has been 24. Her postnatal oral glucose tolerance test show her fasting reading, you can see at 6.1 is actually elevated, not a lot, but slightly elevated. Her 2-hour post-glucose load at 8.8 is elevated, but it's not significantly elevated. It's actually quite a compressed rise. So Charlotte had been treated for gestational diabetes, and let's bring up her family tree. So this is Charlotte's family tree, and the arrow pointing to the circle, that's Charlotte. So on this chart, we've got females are circles, males are squares. If you look, all the people who are highlighted in black are family members that were affected with diabetes. So you can see we've got Charlotte, then we go up to Charlotte's mother, and Charlotte's grandmother unfortunately had passed away when we were doing testing. But we've got a 3-generational family history here. We can also see that Charlotte's sister has also got diabetes, and then we go over across to the other side, and she's got an aunt and uncle who are twins who have also got diabetes. So if we fill in that chart a bit more, if we look at Charlotte's sister, she also was diagnosed with gestational diabetes at age 24. Slim again, the BMI was 22, required insulin in pregnancy. Her glucose tolerance test, fasting at 5.9. As I say, it was slightly elevated, but at 2 hours, at 2 hours it was 7.6, not at 0 hours. That's my fault on there. So again, only a slightly compressed raise, not significant. Her mum, again with a BMI of 22, had been diagnosed with gestational diabetes and then was being treated as type 2. And on the other side of the family, if I go up to Charlotte's grandmother, her grandmother unfortunately had died of cancer. She was diagnosed later in life and was only on a small dose of a sulfonylurea. She was on glibenclamide and had no complications. Going over to Charlotte's aunt and uncle on the other side, BMIs for both of those slightly raised at 28, but they were both diet controlled, weren't needing any medications. And those of you that are managing people with diabetes know that it's very unusual to see this many people with diabetes managed by diet or not very much else. It's very unusual. Normally, if you've got type 2, you tend to find that your BMIs tend to be a little bit bigger and we see other issues going on. But for Charlotte's family, we don't see that. So for Charlotte, obviously we're querying what's the diagnosis. She had bloods taken. Her antibodies were negative. Her C-peptide was positive. Again, she wasn't on insulin. We saw her because she was post-pregnancy, so we expected that. But it's nice to have that information to hand because it also helps the long-term research as well. And Charlotte's diagnosis came back as having glucokinase MODY. So this chart is quite a good one for showing the progression of HbA1c and fasting blood glucose with glucokinase. So patients with glucokinase mutations have a stable, mild hypoglycemia. So they have a slightly higher blood glucose level than the rest of the population. So their HbA1c runs between 40 and 60 millimoles. Fasting blood sugars for them between 5.5 and 8. So as I say, just slightly higher than the rest of the population. And if you look at this chart, although the HbA1c gradually declines as they get older, it's the same for the population that don't have diabetes. There's not a significant jump. So if I give you a bit more information about glucokinase is quite common. 1 in 1,000 in the population will have this mutation. And often it's picked up during routine medical screening, pregnancy. So we often see this in our gestational ladies. So glucokinase doesn't need treating, and although it falls under the monogenic diabetes umbrella, they don't actually need to be coded as having diabetes. For if you're working in primary care, you don't need to be doing annual reviews. They don't need retinal screening. Someone with glucokinase, their fasting blood sugars run higher, but that's normal for them. So they're not at any more risk of diabetes complications than the rest of the population because this is their normal parameters. In pregnancy, it used to be people were very often treated with insulin, but if we can identify that the fetus has the same mutation as mum, then there is no need for any treatment, because what you've got is, if mum's pregnant, she has the glucokinase mutation, her sugars are running higher. If the baby's got the same mutation, that's perfect, because the baby expects a higher blood glucose level, which will be sustained by mum. Where you might get these large macrosomic babies is when, or large births, is because mum will have the mutation, so she's got extra glucose sloshing around for the baby. If the baby doesn't have the glucokinase mutation, then it's getting extra glucose it doesn't need, and it can't manage that. So that's why we do need to monitor it, and we do need to be aware for pregnancy. We sometimes see this quite a lot in in children and adolescents, who often present ill, and they do a random glucose on them, and that's when we pick up these random hypoglycemias. They're ones that we can pick up, but the good thing about glucokinase is we don't need to treat this. You don't need routine screening. Once we've given you a diagnosis, explained to you how it manifests, your risk of developing type 2 diabetes is the same as the rest of the population. So as you get older, you'll need your routine screening as everybody else does. But the glucokinase does not cause you any problems. It's if you develop diabetes on top of this, or if you're at an age where you can become pregnant, then obviously we then need to look at how we're going to manage the pregnancy. Is that all right for everybody for a summary of glucokinase?
Wow, that's pretty amazing. So I can certainly look back over, because I worked in neonates for a time, and I can certainly think there were probably quite a few women who were on insulin unnecessarily, you know.
Yeah, and a good way of picking up, if any of you are midwives or working in antenatal clinics, looking at your ladies who are slim, you know, your below normal and below BMIs, who've got this compressed rise. So often what's a typical picture is you'll do your fasting, your oral glucose tolerance test. So your fastings will be slightly elevated, which you would expect. And then your 2-hour post-glucose load, you often don't get much more than a 3 millimole rise. That's always quite significant. So if you're seeing that and a slim person, then I would be looking at, have we possibly got a glucokinase mutation here? So they're quite a good one to pick up. And I know that some areas have done projects trying to identify glucokinase in their pregnant women.
Wow. Oh, so got a question from Alison. What happens to the fetus if you treat mum's glucose levels to bring them lower? If you don't know she has glucokinase, but a baby is affected, so we'll be seeing lower glucose levels than required.
Yeah, and it doesn't cause any impact to the fetus because you're managing the sugars that are getting to the baby. Unfortunately, you cause problems for mum. Because unless you know if you don't know she's got glucokinase, you're going to be trying to get her fastings down to sort of 4 to 7, but her fastings are never going to be that. You'll be able to get them down temporarily with insulin, but she will reset back up to where she normally runs. So you then find that you're making people feel quite ill because you're trying to get their insulin and their glucose levels back down to what's normal parameters, but they don't fit normal parameters. So it's not that you're going to cause significant harm to either of them, but you can cause hypos. And it's not, it won't come across as a hypo because mum's hypos will be slightly higher than someone without diabetes, but it doesn't cause any problems with the baby. So, okay, so if we move on to Jack. So Jack was picked up a few years ago now, but when we picked Jack up, Jack was seen in a secondary care clinic. He was he was 17 when we saw him. He'd been diagnosed at age 16. And he'd been diagnosed with type 1 diabetes. He'd got fasting blood sugars of 7.7. He was only treated with a basal insulin initially only, because that was all he seemed to need. And his HbA1c was 51. I've just put on here, just to throw that out there, what other information would be helpful? Or is there anything else out there that you think we should be looking at then if we're going to start considering MODY? Because obviously we're talking about MODY and that's what we're going to consider.
Family history.
Perfect. Family history is definitely the next thing that we would look at. So if we look at
antibodies in the chat.
Oh, perfect. Brilliant. Yeah, antibodies. You see, you're already thinking down that route. So the first thing we do was family history. So if we look on here, we've got Jack as the little black square to my right with the arrow pointing at him. So we've got Jack who's got diabetes. his father has got diabetes, and his paternal grandmother had diabetes, and unfortunately she was dead at the time when we were investigating. The cross there between Jack's mum and dad just denotes that they were divorced, and this is where sometimes coming into genomics and genetic medicine from a diabetes specialist, I hadn't really done many family trees and family history. Our families are never what they expect them to be. There's never a normal family. There's no such thing as a normal family. So the issue is, and it raised interesting conversations for us. So Jack's mum had nothing to do with his dad anymore and didn't really want him to be involved. Jack, when we saw at 17, did. So we had lots of conversations, and we involved the clinical genetic counsellors at this point, because Jack technically was under 18 and was classed as, although he's an adult, he's still a child, he's in that transitional period. We did testing on Jack because we went on further, and as you said, somebody put in the chat, did we do antibodies? We did. So we did do antibodies, which were negative. He was obviously C-peptide positive because he was still early on. So he still could have been a type 1 if his antibodies were negative because of the C-peptide. It's too early to tell us, but we know that he's producing insulin. We went on and tested, I'll take you on to the next slide, might be easier. We went on and tested Jack, and Jack had got the HNF1 alpha mutation. We eventually, about a year down the line, got some more information. Dad became a little bit involved, but he disengaged and has had nothing more to do with the diabetes after this. At the time that we got a positive diagnosis for Jack, his father was in Patwes having quadruple heart bypass. His dad had diabetes age 22. He'd gone straight onto insulin. And his mother had also gone onto insulin at age 22, and she died from complications of that. His dad had never managed his diabetes particularly well. And there was an acrimonious separation between Jack's mum and dad, which is why we didn't have a lot of information. But Jack's mum was actually quite angry because Jack's dad because he'd been perceived as not managing his diabetes, he'd had retinal damage, so his eyesight wasn't very good. He'd also got, he'd lost a couple of toes, and mum was very angry, saying it was him not managing it. Looking back, we also hadn't managed Jack's dad very well because he was on the wrong treatment, he was on insulin. Now, people with 1 alpha do not respond as well to insulin as they do to sulfonylureas. So we got Jack straight onto sulfonylureas. We got him onto a small dose, got him off basal insulin. So he went onto gliclazide, 40 milligrams. We tried him on 20, that wasn't quite enough. Put him up to 40, and his last HbA1c was 42 millimoles. And for those of you managing diabetes, you know that's an excellent response. And for Jack, it's life-changing. We've got him off insulin, we've got him onto tablets. He was learning to drive. It made a huge difference to him. Back to the family tree, I'd also got blacked out on there. Hope was diagnosed. When we saw Jack at 17, Hope was 14. Hope didn't have diabetes, but both Hope and her mum wanted her to have pre-symptomatic testing. Because Hope was only 14, she went through the clinical genetic counselling route, because we won't just routinely screen children without having that conversation. Hope had her first appointment, and actually mum had done some glucose testing on Hope in the run-up and just after that, and her glucose levels were spiking. So actually we expedited Hope's testing, and Hope was diagnosed shortly afterwards with the same mutation, the HNF1 alpha. The difference being, because we knew what we were dealing with Hope, Hope went straight onto sulfonylurea, so she didn't even need to go to insulin, and she's on 20 milligrams once daily. So just to sort of summarise the 1 alpha, and 1 alpha is the most common type of MODY that we see in the UK. It's characterised, as I say, by the inheritance pattern. So each child has a 50% chance of inheriting it from the affected parent. Young age of onset, we often see these young, often in their teens, but usually under the age of 25. They don't need insulin because they respond at a cellular level to sulfonylureas, not so well to insulin. As they grow older, they will need insulin at some point in their life, but hopefully we can get many years before we reach that stage. And it's caused by progressive beta cell defect. Most commonly presents, as say, in adolescence is when we see it. And the thing with the 1 alpha patients, which is why it's significant for Jack's dad, is that they are prone to microvascular and macrovascular complications earlier on than people generally with diabetes. So they have a history of myocardial infarction, is quite common at a young age. And just to show the chart that we showed earlier with the glucokinase chart, so you can see glucokinase is on here in the green, steady gradual rise as people get older, the same as people who don't have diabetes. For the 1-alpha patients, it's a significant jump, and these are why they often get misdiagnosed as type 1, because they present with osmotic symptoms, you know, thirsty, polyuria, polydipsia, very high blood sugars. So you would do the safest thing, which is treat them with insulin, but then quite early on investigate for monogenic diabetes. So any queries for 1-alpha before I move on to the next one?
So the 1-alpha patients, they would need retinal screening and the usual diabetic checks.
They would stay under secondary care to be kept a close eye on. They can be managed, obviously, in primary as well, but you'd want a consultant overview of these patients.
Oh, but I mean, it's fantastic that they can be treated on glycoside and things like that without having the, I suppose, the complications that insulin brings for a number of years. Yeah,
it's life changing for people. So.
Yeah. And I mean, it's so sad for his dad that he was on insulin probably unnecessarily for a lot of years. So.
Yeah, and there's a lot of people out there, and you know, his dad, you know, the mum was very angry about dad, but was it because we weren't treating him? There's an element of lots of things going on, but that's when you deal with families, it's always complicated.
Yeah. Oh, that's great. Thank you.
Okay, so let's move on to Alice. So Alice was diagnosed with type 1 at age 19, presented with osmotic symptoms, slim with a BMI of 23. HbA1c was only 53. She was on a small basal background insulin of Levemir and NovaRapid 4 to 6 units with meals. Now, this is an interesting case, and I'm bringing in Jeanette here. Jeanette, who is Alice's mother, was diagnosed at age 29 during pregnancy in 1988. She needed insulin in pregnancy and remained on insulin after a third pregnancy. She's slim with a BMI of 21. Jeanette is now, well, at the time when we did this, we're a few years on, but Jeanette was age 56 when we got involved. And Jeanette is one of these people that always said she felt her diabetes was different. She saw an article in the Times newspaper by Professor Andrew Hattersley, who's one of my leads from Exeter. He'd written an article about MODY. She saw that and made contact via the website, because you can go and find your local genetic diabetes nurse. So Jeanette was the first one we got involved with, but simultaneously we're dealing with Alice at the same time. So if I bring up the family tree. So Jeanette, I've put the arrow next to, because that's the one that we're dealing with now. But Jeanette came to our clinic at Norwich she was been told she's type 1.5, which isn't even a diagnosis, but she wasn't a type 2 and she wasn't a type 1. But she'd been on insulin for many years, been on insulin since late 1980s. Alice had just been diagnosed when Jeanette saw us in the clinic, and she saw the article by Andrew Hattersley. We took a family history. We've got a 3-generation family history. What else are we going to look at? What other things do we need to look at before we do the genetic testing? We've got family history.
C-peptide.
Yeah, C-peptide. And actually C-peptide in Jeanette is a really good one. Not so helpful in Alice, because Alice is just diagnosed, but Jeanette's been diagnosed for many years. So she's got a positive C-peptide. That's definitely not type 1. We did antibodies on Jeanette. We tested Jeanette first off because she was C-peptide positive and antibody negative. Once we got Jeanette's results back, and Jeanette came back as having HNF4 alpha. So it presents very similar to 1-alpha. They're interchangeable when you first see them, but we identified 4 alpha. As soon as we identified 4 alpha, we got Alice off insulin and straight onto sulfonylureas, the same as we did with Jeanette. Now, Jeanette took a little while to get her off insulin because she'd been on it for nearly 30 years. And had always been told, you need insulin, you need insulin. If you don't have insulin, you become very ill and you could die. So it's very difficult for people to suddenly just go, no, we don't mean that anymore, you can swap. So it took a lot of time spent with Jeanette to get her confident, get her off. But Jeanette is now successfully managed on sulfonylureas. So is Alice. The thing I've left the family tree up here is, if you look at Jeanette's children, so if you look at Alice's birth weight was £8.13. Her sister's was £9. So we've got large birth weights. let me come off here for a minute. So if we go and go into here, so HNF1 alpha presents very similar as 4 alpha. The differential that you'll often see with 4 alpha patients are these large babies born, large birth weights, and often having hypos at birth. With Jeanette's family, we had another family member, her son, we did pre-symptomatic testing. He was positive for the mutation, but hadn't developed diabetes. He informed us when his wife was about 5 months pregnant that his wife was pregnant. So we would like to have known sooner. But once we identified that his wife was pregnant, we knew that he had the mutation. We did fetal blood tests, which we took from mum's blood. So we didn't have to do amniocentesis. We could take blood tests, and we did fetal DNA testing, and we sequenced the baby's DNA, and we identified that she had the 4 alpha mutation. How that was beneficial was that when baby was born, we often see with these babies are severe, significant hypoglycemic episodes at birth, which is quite frightening. So this baby did have a severe hypo and a significant hypo, and we actually ended up getting Great Ormond Street involved in the long term, but it was managed. Paediatric teams were on standby. We had everybody there. So although it was scary for mum and dad, the fact that everyone was prepared, it was managed, it made it much better experience than it potentially could have been. And that's the advantage we have now. Not only are we able to screen the family, we're able to screen an unborn child for what her DNA was to see if she got the same mutation, and then have plans in place when that baby was born. And for being involved in this, it's incredible. It really is. So I'm going to move on to Oliver, because I realise I'm yakking quite a lot here, and I've just looked at the time.
I was just saying, I've had a comment from Eleanor,
Okay.
And she said, I've got patients who prefer to stay on insulin so they can keep their Libre. So I assume that means their disability living allowance or whatever.
No, it's the Libre is the sensor that you use.
Oh, Libre. I was trying to work out what that was.
What's that? Yeah, it's the sensor. So type 1s automatically get the Libre. It's tricky because actually they may well get better control off. And if we know what the gene is and they've got good C-peptide production, well, then we would be advocating getting them on sulfonylurea if that's the correct treatment for them. Again, patients have the right to make their own decisions, but they won't get as good control without that. But it's choices, isn't it? And that's where you get these dilemmas come up.
Absolutely. Oh, okay. Yeah, sorry, I'll let you get on with Oliver.
Yeah, so we've got Oliver and one more, so I'll whip through these. Oliver is actually one of the rarer cases. So this goes against what I've just told you. So Oliver was diagnosed at 29, slightly older than other cases. High blood sugar, a very high HbA1c of 154. Slim, no family history. So he was advised he'd got type 1 diabetes and started on insulin. He'd also got a diagnosis of, well, we say Asperger's, but actually it's autism now, and I should change that because I know prefer to use the word autism. GAD and IO2 were negative, C-peptide was positive. We diagnosed, excuse me, with Oliver, HNF1 beta. Now, HNF1 beta is a syndromic collection here. So although it's MODY, it also involves the kidneys. And often what you see with these group of patients are they have unusual shaped kidneys, they have missing kidneys, they have cysts in their kidneys, and they're often seen in a renal clinic before the diabetes presents. And what's interesting is with the HNF1 beta MODY, if they've got a whole gene deletion, often those group of patients have the whole gene. We often see this goes along with the autism diagnosis as well. So there's obviously a link there with the two. If it's not a whole gene deletion, then you don't see that autistic spectrum diagnosis as well. So it's interesting that you get this multifaceted approach with one mutation, but we get a whole syndrome that goes on. This for this gentleman, this is what we called a de novo mutation. So neither his parents had got it. So we talk about get family history. You do always get the exception to the rule, and Oliver is a good case. This is a spontaneous mutation that had happened, hadn't got in his parents. He's still got a 50% chance of passing this on, but it started with him. And just to say that if they're under renal clinics, we often say, have we checked fecal elastase? Because this is often low, and they often have very low magnesium levels as well. We've seen patients in clinic who've had central lines inserted to replace magnesium, but it doesn't actually help. They will still keep losing it at the same rate. Oliver was tried off insulin, but insulin is the correct treatment for him, and it wasn't successful. And again, it just shows for these patients, so renal system diabetes is quite common, and often they're seen in the renal clinic before they get to the diabetes clinic. So again, just bear in mind, patients who've got unusual presenting diabetes, is there a history of any renal problems? That's another one that we look at. Okay, I'm going to go on to our last case because I'm very aware of time. So this is Josie. Josie was diagnosed slightly older in our clinic. She was age 34. She was initially on metformin, but she progressed to insulin very quickly. She had a history of tiredness all the time, migraine, general muscular aches and pains, and some hearing loss. And if you look at her family tree, you can see there's a clear maternal inheritance going on here. And I've said that just for speed as well. I would normally have asked you a bit more to pull out. But if we look, Josie's mum, her maternal grandmother, and her maternal great-grandmother all had diabetes. Those in grey on here have got deafness but haven't got diabetes. When we investigated a bit more, there was also a family member that doesn't show on this tree who died of something called MELAS, which is quite a nasty presentation of a mitochondrial diabetes and deafness, and it can lead to stroke-like episodes and unfortunately death, which happened in this case. If we look at maternally inherited diabetes and deafness, you don't always get deafness, although that is what it's predominantly known for. We do say look for deafness in a young age. So you're looking at a sensorineural deafness. Because it's caused by a change in the mitochondrial DNA, it's passed on by the mother to all children. So if the mother has sons, the sons will inherit a degree of this mutation, but they cannot pass it on to their children. But what we cannot tell is what the penetrance of this disease will be. And like the 1 beta, this one is quite syndromic. So you can get muscular aches and pains, you can get cardiac abnormalities, you can get problems with the eyes, blindness at a young age can be an issue, lactic acidosis. So we don't tend to treat them with metformin because there is a slight risk of that. There's quite a lot with this one, and it's one of those ones that when we identify it, you often again will need to go down the route of clinical genetic counselling for families, because obviously the impact it's going to have, and whether they want to look at children, having children themselves, is having that awareness that this will go on to passed on to all the children from the maternal side. So if we summarise then with a summary of cases, glucokinase, mild high blood sugars, slight, and we say mild, fastings of 5.5 to 8. No treatments needed though. HNF1 alpha and HNF4 alpha present like a type 1, very high sugars, symptomatic, but they are both sensitive to sulfonylureas. The 1 alphas, which we didn't show in the case study, actually have a low renal threshold, so they will pass, if you do a urine dipstick, they will have glucose in the urine before you see an elevated blood glucose. And again, it's just something just to be aware of if you're taking notes from patients. The 4 alphas present the same, respond to sulfonylureas. They just have these large babies at birth with a possible significant hypoglycemia. The mitochondrial inherited diabetes and deafness, look for an odd syndromic presentation of diabetes, and if there's a history of deafness at a young age, and as I say, it's a sensorineural deafness, not just a blanket, oh, I can't hear, it's quite a high pitch level that they struggle with. The KCN J11, I apologise, I didn't put a case study in because I knew we'd be short for time, but basically anybody diagnosed under the age of 6 months of age gets automatically sent for genetic testing. We don't even need to discuss that. That's an automatic send because they probably have neonatal, and then obviously we'll look at specialist advice if we get that diagnosis. And the 1 beta, which is the other one that we talked about, which is diabetes and renal cysts with a low fecal elastase, low magnesium, and often will need insulin. So it's just bearing in mind with all of this, and it's a lot to go through, I'm afraid, it's not based on a single criteria or a single investigation, except for neonatal. If your patient was diagnosed under the age of 6 months, that's easy. Send them, they'll need to be sent for genetic screening for neonatal. but it's a multifaceted approach. We talked about all the tools we've got at our disposal to use, and it's just picking out family history, antibodies, presentation, and other complications they might have going on. That last slide is just showing our pickup rates for our area, and we're getting better. So it does show our pickup rate is getting better. And that slide there is just reiterating, we've got the Future Learn website where it's got links to our regional meetings because we have those quarterly, and the diabetesgenes.org website, who run 2-day study days. They've just held one last week. They were holding them, so they'll probably be in another 3 or 4 months, another 2-day study day. Gosh, I have talked very quickly at the end there. I apologise.
No, that's been fantastic, Anita. We've just got a question from Alison. So she's saying obesity is becoming more popular, becoming more common, not popular. I make it sound like it's a desirable state, don't I? So could it be possible for a patient to have MODY and be overweight coincidentally? So she's thinking, if we've got a young overweight patient with a strong family history, should we be thinking about testing for them?
Definitely. And it's interesting because generally as a population, we are getting bigger. So although we say typically MODY is slim, if the population is getting bigger, then yes, our parameters will change. So having a larger BMI isn't a rule out. It's just one of those things to bear in mind. And if you're looking at someone who has, is larger, you're looking at someone, particularly if we're looking at someone who's obese, look for acanthosis as well. Look for your insulin resistance, just to see, is there possible insulin resistance before we go down that route. Type 2, we know, appears in families. It does run in families. And type 2 is always very difficult to differentiate because you've not got that clear C-peptide measurement because they're often not on insulin.
And then another one, can the calculator be used for all ethnic groups, or is it focused on the white UK
No,
population?
at the minute, unfortunately, the reason it's based on a Caucasian population is because that's where we've got the most information from. As we're getting more and more testing coming in from other countries, they are looking at, as I say, I know that Dr. Shivani Mistra was looking at developing one for South Asian population, but we need the data in from these groups of patients to be able to then get enough data to put together a calculator. So they are working on it, but at the minute, unfortunately, it is just on a Caucasian population.
Okay. So has anybody got any more questions or comments? I mean, that was fantastic, Anita, and it's
a lot.
I know it's a lot, and it's great because we want to keep these sessions quite informal and sort of very practice-based. So I'd like to thank you for your time and amazing presentation, and to thank everybody for joining. And next month, well, middle of next month, our next bite-sized session is about some of the practical issues of genomic testing, so consent, and then sort of working as an isolated practitioner, how to get support in the trust. So, we're doing that next month, so that will be good.
That'll be good. That'll follow on nicely from this, actually, because we've talked about monogenic, but as we've discovered, it isn't just that person in front of you. You've then got to follow up the family, so that'll be really good, actually.
Yeah, and I think, obviously quite a lot of trust policies and procedures, they focus on individuals rather than families. So that'll be quite an interesting one. So that's great. And and we'll send out a feedback survey, and any comments, yes, it will be possible to send the slide, and we'll put the link in our our newsletter. We put the links to the recording so people can watch and catch up, as they might do with Netflix or whatever.
Netflix is a bit more interesting.
So got lots and lots of really positive feedback, really interesting. Thank you. Excellent talk. So amazing, Anita. Lovely. Thank you.
Okay. Lovely. And then hopefully, if you're all in our area, if you want to join our quarterly link groups where we always have informal chats about case studies, please come along to those as well.
Yeah, and the 2-day study days that Anita mentioned, which are virtual, aren't they?
Yes, they are virtual. Yes, I should have said they're virtual.
Run by Exeter. So if there's any diabetic nurses out there that would like to enhance their practice, this is a great opportunity.
Lovely.
Okay
Brilliant.
then.
Thank you very much, everyone.
Thank you.
Thanks, Em. Bye-bye.